Diabetic foot is dangerous because the patient is not in pain, because he does not go anywhere. And only in the evening he notices that, for example, somewhere in a slipper there is a speck of blood. We have the right to make a diagnosis such as a diabetic foot only when there is some kind of trophic disorder. Callousness is not yet a diabetic foot. This is a signal that an ulcer will soon be in this place. When there is damage to the skin, it is a diabetic foot. The only thing that falls out of this definition is Charcot's neuroosteoarthropathy, a very interesting complication of diabetes mellitus where the bones begin to crumble and heal incorrectly, forming an additional fulcrum on the foot where we have not stepped before. For example, if there is a failure of the foot, the patient steps on the inside of the foot. We have an additional point of pressure, and this leads to calcification, then hyperkeratosis, which means a prerequisite for the appearance of an ulcerative defect. An ulcer is an open gate for infection, gangrene, amputation. Therefore, the patient must perceive all these problems not from the point of view of sensation, but from the point of view of understanding what follows. Better to see a doctor in time, there are no spare legs. Everything related to the diabetic foot is very scary and very difficult. The problem is precisely the lack of sensitivity. You stepped on a stone, it hurts. You are walking along the beach, you stepped on a shell, you felt pain, and you paid attention to it. You saw a wound. If you saw it in time, you washed it, processed it, bandaged it. We intervened and prevented further complications. A patient with diabetes mellitus steps on a shell is also injured, but he does not feel pain. For example, he goes further with this shell fragment, and only in the evening can he notice that somewhere in the slipper there is a speck of blood, and only then he pays attention to it. He saw it, but he did not feel it. This means that he did not intervene in time. This means that it launched a whole cascade of complications. Pain is not a disease, pain is a symptom, a signal. Patients with diabetes mellitus, unfortunately, are deprived of these sensations. A banal home procedure using a blade in case of trauma can do a lot of harm. For such patients, a variant of a medical procedure has been created when a specifically trained person does the treatment of the foot, at least with secondary medical education. Who knows to what level it can be processed, where it can be processed, and for how long. Because even at this stage of a procedure, harm can be done. If the person who does the procedure does not know how to work with patients with diabetes mellitus, does not know that they have lost sensitivity, does not know how to determine the pulsation on the leg, firstly, a cut will bring a cascade of problems, and secondly, long-term processing. If you are treated for a long time in one place, then due to friction, you feel a burning sensation, pain. You say, "Oh, let's stop." At this stage, the patient will not feel this. If a procedure is done by an unprepared person, then he may, on the contrary, create a problem. First, it may not be as fast as you want it to be. Sensitivity is restored gradually with the use of certain groups of drugs. And the most important thing is sugar compensation. Sugar should be no higher than 10 for the drugs prescribed by the doctor to start helping. The drugs will work anyway, but the patient will not see it. Destruction will be faster than recovery. Therefore, the most important thing is sugar compensation, conservative treatment. There are many groups of drugs that are used for neuropathy. By choosing the right duration of taking these drugs, by choosing the right dosage, you can achieve a return of sensitivity. There is also the option of using nerve tissue growth factors. It is used both for the healing of the ulcer defect and for the restoration of sensitivity. This is done by injection, but without a clear sugar compensation, nothing will work. In my practice, there are patients for whom we have restored sensitivity against the background of an ulcer, and this is not good. An ulcer is a defect on which the patient constantly steps. People are different. Someone listens to the doctor, someone hears him. Someone understands that if the doctor says that certain unloading is needed, then he follows the recommendations, but someone does not, and he continues to step on long-term non-healing ulcers, which may not be a week or two, but a year, 5, 10. That is, the patient constantly walks on this ulcer. And if we return sensitivity to this foot, we have a problem. The patient begins to feel his ulcer, pain, syndrome returns. On some side, this is good. The person felt the ulcer and will now spare this area. But we miss the emergence of neuroosteoarthropathy changes in the foot, resolution when, unfortunately, all this will not recover. The person is forced to have an offensive load. Yes, all this is corrected by additional Scotch casts unloading in the form of orthopedic shoes, but not everyone can afford it. Prevention is better than cure. Let me rather spend on a medical pedicure, on more competent high-quality shoes, on a properly made individual orthopedic insole, on orthosis options that will soften, correct, maintain, strengthen, than I will spend on treatment later. And from the point of view of the doctor, I can say that when the patient comes earlier, this problem can be corrected. Then we part with the patient with a smile.